Hello everyone, this is Dr. Surbi, and in this video series I'll be covering hypertension. The first part will include the regulation of hypertension and the JNC8 guidelines. The second part will include the classification of hypertension, that is the primary and secondary hypertension, and third part will include the classification of antihypertensive drugs and their detailed information. So, hypertension, how it is defined? It is defined as the systolic blood pressure greater than the 95th centile for age. Okay, so the systolic blood pressure, if it is more than the 95th centile for that particular age, then it is classified as hypertension. Now, blood pressure, what we say, can be systolic or diastolic. The systolic blood pressure is dependent on the cardiac output, as we know, and the diastolic is dependent on the total peripheral resistance. Another term we should know is the mean arterial pressure, which is equivalent to the diastolic blood pressure plus 1/3 of the systolic blood pressure. Okay, this is the formula which you have to be learning on your tips. It is diastolic blood pressure plus 1/3 of systolic blood pressure. Okay, so this mean arterial pressure, it should be differentiated from the mean systemic pressure, MSP. The mean systemic pressure, it is the pressure which is maintained in the systemic circulation when there is no cardiac output. That is, the heart is not working. When the heart is not working, the pressure maintained in the arteries, capillaries, and venules, it is called as the mean systemic pressure. So, mean arterial pressure, it is the pressure when there is cardiac output present. But if there is no cardiac output, that is, the heart is not working, and that at that time the pressure maintained in the systemic circulation, that is the arteries, capillaries, and venules, is called as the mean systemic pressure. The mean systemic pressure is approximately 6.5 millimeters of mercury, and it is very important that you should not confuse between the mean systemic pressure and the mean arterial pressure. These two terms are totally different. Mean arterial pressure when there is presence of cardiac output. Mean systemic pressure when there is no cardiac output and the heart is not working. Okay, and this mean systemic pressure, it maintains return of blood from the tissues to the heart even when it is not working. Okay, so as we have studied in physiology, that the blood pressure is dependent on the cardiac output and the total peripheral resistance. So cardiac output, it is dependent on two factors, the heart rate and the stroke volume. And remember, the cardiac output is going to reflect to the systolic BP. That is, changes in the cardiac output will change the systolic BP, while the changes in the total peripheral resistance, however, will change the diastolic BP. Okay, so the cardiac output changes the systolic BP. The cardiac output further dependent on the heart rate and the stroke volume. Cardiac output is the heart rate and stroke volume, right? And changes in heart rate and stroke volume will affect the cardiac output. Stroke volume will further be affected by three factors. One is the preload, second is the contractility of the heart, third is the afterload. The preload, that is dependent on the end diastolic volume and the pressure of the ventricle, it will further depend on the venous return. Okay, the venous return is a factor that is affected by the ventricular filling pressure and the filling interval. The ventricular filling pressure is further dependent on the venomotor tone and the blood volume. I'll just explain a little more everything. The preload that is dependent on the end diastolic volume and pressure, that is at the end of diastole, that is when the heart is relaxing. At the end of the diastole, the volume and the pressure affects the preload. Okay, this preload is dependent on how much venous return has been there during the time of diastole. Okay, now the venous return that is the blood that has gone to the heart during the diastole, it depends on the ventricular filling pressure, which depends on the tone of the blood in the veins, that is the venomotor tone, and also dependent on how much volume of blood is there. So venomotor tone and blood volume, it affects the ventricular filling pressure. And secondly, the venous return also depends on the filling interval, that is the time during which the blood is filled during diastole, that is the diastolic interval. As the heart contracts faster, that is the heart rate is more, there will be less time for the heart to fill during diastole. So the diastolic interval will be short and the venous return thus will be less. Okay, so diastolic interval, that is the time the heart is relaxing and is filling, is the diastolic interval. It'll further reflect the venous return. The faster the heart rate, the lesser is the diastolic interval and lesser is the venous return. Okay, so these factors, they affect the preload. Second is the contractility. More is the contractility of the heart, more will be the stroke volume. Okay, and third is the afterload. And afterload, it is actually inversely related to the stroke volume. The stroke volume will be inversely related to the afterload. That is, more is the afterload, that is, more is the total peripheral resistance, less will be the stroke volume. Okay, now second part that affects the diastolic BP is a total peripheral resistance. It also somehow affects the cardiac output also, because it decreases the stroke volume and decreases cardiac output, and thus affects the systolic BP. Now it is clear, right, that the total peripheral resistance, it also affects the systolic BP, because it decreases the stroke volume. Decrease in stroke volume will decrease the cardiac output, and decrease in cardiac output will decrease the systolic BP. And total peripheral resistance, it will increase the diastolic BP, however, and because it depicts the arterial tone and increase the diastolic BP. So inverse relation of total peripheral resistance with systolic BP and direct relation with diastolic BP. Okay, the total peripheral resistance is directly related to diastolic BP, and the total peripheral resistance is inversely related to the systolic BP. Okay, so now, as we have discussed, that the mean arterial pressure is directly related to cardiac output and total peripheral resistance, but they are not independent variable, rather they are interdependent. As we have said, if the total peripheral resistance increased, there will be decrease in the stroke volume, there will be decrease in the cardiac output, thus the mean arterial pressure will not increase much overall. Okay. So next we'll discuss the regulation of BP. So there's short-term regulation and one there is long-term regulation. So short-term regulation of blood pressure is done neurologically, while the long-term regulation is through the renin-angiotensin-aldosterone system. So first we'll discuss the short-term regulation, that is under the neurological control. Short-term regulation. So it is done by the baroreceptors. So first, looking at the right-sided diagram, there is a presence of baroreceptors in the carotid sinus and the aortic arc. The carotid baroreceptors, they are taken, the afferents, they are taken through the ninth, that is the glossopharyngeal nerve, while the baroreceptors in the aortic arc, they take their afferents through the vagus nerve, that is the 10th nerve. The baroreceptor afferents, these contain glutamate in the as a neurotransmitter. So the carotid and the aortic arc baroreceptors, the carotid and the aortic arc baroreceptors, they have glutamate as neurotransmitter, and these baroreceptors, they sense an increase in the blood pressure or a decrease in the blood pressure. Now, first taking instance of an increase in the blood pressure, which is sensed by the baroreceptors. The increase in the blood pressure sensed by the baroreceptors will activate the nucleus tractus solitarius that is present in the medulla. So, the baroreceptors take the signal to the medulla, to the nucleus tractus solitarius. Okay. So, nucleus tractus solitarius then affect the ventrolateral medulla. So, ventrolateral medulla, it is divided into the caudal ventrolateral medulla and the rostral ventrolateral medulla. Okay, so first affected is the caudal, second affected is the rostral ventrolateral medulla. When the nucleus tractus solitarius, is activated, it will activate the caudal ventrolateral medulla. The caudal ventrolateral medulla will inhibit the rostroventrolateral medulla. Okay, this is the sequence. The rostroventrolateral medulla then affect the sympathetic system. Okay. Normally, the rostroventrolateral medulla, it will activate the sympathetic outflow. Okay, it will activate the sympathetic outflow, will help in increase in the blood pressure. But when the rostroventrolateral medulla is inhibited, the sympathetic outflow is inhibited. So, when the baroreceptors are activated, they'll activate the nucleus tractus solitarius. The nucleus tractus solitarius will then activate the caudal ventrolateral medulla, CVLM, caudal ventrolateral medulla. The caudal ventrolateral medulla then will inhibit the rostroventrolateral medulla. The rostroventrolateral medulla, normally it activates the adrenal medulla and the parasympathetic preganglionic sympathetic neurons, that is releasing ACH. So will these actually control the sympathetic outflow. When the rostroventrolateral medulla is inhibited, it will inhibit the release of the sympathetic outflow from the adrenal medulla or the sympathetic neurons, and thus sympathetic outflow will decrease, and thus will help in decreasing the blood pressure. Just looking at the diagram on the left, making it easier, activation increase in the blood pressure here, it will activate the baroreceptors in the carotid sinus and the aortic arc. Okay, that will in turn activate the nucleus tractus solitarius that is present in the medulla. Okay, this nucleus tractus solitarius activation will further activate the caudal ventrolateral medulla. Activation of caudal ventrolateral medulla will inhibit the rostral ventrolateral medulla, which will inhibition of rostroventrolateral medulla, the sympathetic output will decrease. Decrease in sympathetic outflow will decrease the heart rate, will decrease the stroke volume, will decrease the total peripheral resistance. This decrease in heart rate and stroke volume will decrease the cardiac output, will decrease the systolic BP, while decrease in total peripheral resistance will decrease the diastolic BP. Okay, so this is how the baroreceptors they help in decreasing the BP if they sense an increase in the arterial pressure. Also, activation of the baroreceptors, they will activate the nucleus ambiguous through the nucleus tractus solitarius. Activation of baroreceptors will activate nucleus tractus solitarius, that will activate the nucleus ambiguous, will increase the cardiovagal output, that is they will increase the parasympathetic output, that is through the vagus. The vagal parasympathetic output will decrease the heart rate and thus will decrease the cardiac output and helps in decreasing the BP, that is the systolic BP. So this is how a short-term regulation of blood pressure is done. So after the short-term regulation, we'll discuss the long-term regulation of BP. The long-term regulation of BP is done by the renin-angiotensin-aldosterone system, that is the RAS system. First, we'll discuss about the three hormones. The renin, it is secreted by the kidneys. Angiotensin, it is secreted in the prohormonal form, that is in the angiotensinogen form through the liver, while aldosterone, it is secreted from the adrenal cortex. Okay, there is one enzyme that converts angiotensin 1 to angiotensin 2, that is an important step, that is known as the angiotensin converting enzyme ACE. Angiotensin converting enzyme is secreted from the pulmonary and renal endotheliums. So, whenever there is a decrease in the BP, that is a decrease that will cause decrease in the renal perfusion pressure. Decrease BP, decrease flow in the vessels, decrease in the renal perfusion pressure, that will cause a decrease in the flow through the juxtaglomerular apparatus, that will cause the release of renin from the kidneys. Okay, from the GJA apparatus, that is the juxtaglomerular apparatus, will release renin in response to a decrease in the renal perfusion. Renin will in turn activate the conversion of angiotensinogen to angiotensin 1. This angiotensinogen, as we have discussed, is secreted from the liver. Angiotensinogen is converted to angiotensin 1 in the presence of renin. Angiotensin 1 in the presence of angiotensin converting enzyme is converted to angiotensin 2. So, angiotensin converting enzyme that is secreted from the surface of pulmonary and renal epithelium endothelium. It is the enzyme that is required for conversion of angiotensin 1 to angiotensin 2. This angiotensin 2 has various mechanisms that will in turn cause water and salt retention. First of all, it will increase the sympathetic activity. Secondly, it will cause the tubular sodium chloride reabsorption and potassium excretion. This in turn will, as sodium is reabsorbed along with the chloride, it will cause the passive diffusion of the water also. Third, it will activate the adrenal gland, that is the cortex, adrenal cortex, to secrete aldosterone. Fourth, it will cause the arterial vasoconstriction itself, thus causing an increase in the BP. Arteriolar vasoconstriction causing an increase in BP. Fifth, it will cause the pituitary gland to increase the ADH secretion. Increase in ADH secretion will lead to increase in the water reabsorption through the collecting duct. The overall effect of angiotensin 2 is to cause water and salt retention. The water and salt retention will increase the blood volume, that is, it will increase the effective circulating volume. Thus, it will cause an increase in the blood that flows through the JJA apparatus, that is the juxtaglomerular apparatus, and thus causing the inhibition of the entire circuit. Okay, so basically, angiotensin 2 and aldosterone, they help in the increasing the effective blood volume, effective circulating volume, and thus increasing the blood pressure. And also there is a direct effect of angiotensin 2 on the arteriolar vessels, and thus causing arteriolar vasoconstriction, thus increasing BP. So this was the long-term regulation of BP through the renin angiotensin aldosterone system. Next, we will discuss the JNC8 guidelines. The eighth report on the Joint National Committee for Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, they have defined hypertension as the chronic sustained elevation of systemic arterial blood pressure. That is, the Joint National Committee's eighth report says that high blood pressure or hypertension is defined as chronic sustained elevation of systemic arterial blood pressure, and the JNC8 has set different targets of systolic and diastolic blood pressure in different age groups, and those with CKD and diabetes, they have given a few recommendations for those as well. So the JNC8 says that in a patient aged more than 60 years, the target systolic BP is less than 150 and diastolic is less than 90. So more than equal to 60 years, the target BP is less than 150, 90. Okay, and for less than 60 years, the target BP is less than 140 by 90. So the target systolic BP for less than 60 years is less than 140. Now, for patients of CKD and diabetes, also they have given recommendations for all patients more than 18 years with CKD or all patients more than 18 years with diabetes. The target BP is less than 140/90. So, all more than 18 years with CKD or with diabetes, the target BP should be less than 140/90. So, the diastolic BP for all patients is target is 90 millimeters of mercury, while for all patients 18 to 59 years, that is less than 60 years, the target systolic BP should be 140, or the patients more than 18 means who are even more than 60, and with CKD more than 60 with diabetes. These patients are also included. Their systolic BP target is 140. Other all patients with age more than or equal to 60 years, their systolic BP is 150. So the diastolic BP goals have been simplified, and all patients, irrespective of age, CKD, diabetes present or not, they have to be managed with diastolic BP equivalent to less than 90 millimeters of mercury. Okay, now they have also defined certain drugs which have to be given according to what is the race of the population and whether they have diabetes or CKD, etc. Now, the general non-black population, they should be prescribed thiazides or calcium channel blockers, or they can be given uh, angiotensin converting enzyme inhibitors or can be given angiotensin receptor blockers initially. While the general black population, this was the non-black population, the general black population, they should only be given thiazides or calcium channel blockers initially. They should not be given ACE inhibitors initially. They should not be given ARBs initially. Okay, the CKD patients, their treatment should include ACE inhibitors or ARBs because they have special role in decreasing proteinuria. There should be up titration or addition of therapy after 1 month if the BP goal is not achieved. And don't use ACE inhibitors and ARBs together, as we know they can cause refractory hyperkalemia. If more than 3 drugs are needed, refer to the hypertension specialist or may be required, because this is the case of refractory hypertension. Right. So to summarize, the blood pressure goals, they need to be set according to age, according to presence of diabetes or CKD, etc. So if the patient's age is more than equivalent to 60 years, the blood pressure goal is less than 150/90. If the age is less than 60 years, then goal is less than 140/90. All ages of diabetes are present but no CKD, goal is less than 140/90. If CKD is present, then also goal is less than 140/90. Now this population, all ages, they have been divided into non-black and then black population. The non-black population, they can be started with ACE inhibitors, ARBs, CCBs or thiazide type diuretics alone or in combination. While the blacks, they have not to be given, they're not to be given ACE inhibitors or angiotensin receptor blockers. They should be only started with thiazide diuretics or calcium channel blockers alone or in combination. All races, whether blacks or non-blacks, if they have CKD, then they have to be given ACE inhibitors or ARBs. Although the non-black population can be given, while the black population without CKD, they are not to be initiated with ACE inhibitors or ARBs. But if the patients, a black population has CKD, then they have to be initiated with ACE inhibitors or angiotensin receptor blockers. Also remember to maximize the first medication before adding the second antihypertensive drug. Add the second hypertensive medication before reaching the maximum dose of the first medication, and start with two medication classes separately or as fixed dose combinations. So for the combinations, we have to remember that we cannot use ACE inhibitors and ARBs together. They cannot be used together. While ACE inhibitors can be combined with calcium channel blockers or thiazides, the angiotensin receptor blockers, they can be combined with calcium channel blockers or thiazide. Even calcium channel blockers can be combined with thiazide diuretics. Also, the beta blockers, they are not preferred as antihypertensive agents in absence of comorbid conditions which are related to heart. Like, they are not preferred. But if the patient has coronary artery disease, or if the patient has congestive heart failure, then beta blockers are a preferred antihypertensive to be used. Okay, so mainly for primary prevention, the first line therapy includes thiazide diuretic, ACE inhibitor, angiotensin receptor blocker, or a combination. If there are compelling indications, it was first described in JNC7 criteria, but now no longer these compelling indications are used. But just to know, if someone asks if there is compelling indication of diabetes mellitus, then ACE inhibitor is the first line of therapy, or angiotensin receptor blocker or ACE inhibitor is the first line of therapy. The sequential therapy can be thiazide diuretics or calcium channel blockers or beta blockers. Chronic kidney disease, ACE inhibitors or ARBs to be preferred. Coronary artery disease, remember the beta blockers are the first line agents, although they are not preferred as antihypertensives in other conditions other than the coronary artery disease or the congestive heart failure. Uh, Subsequent to beta blockers or ACE inhibitors, we can use thiazide for BP control and calcium channel blockers for ischemia control. Okay, if there is a prior ischemic stroke, prior ischemic episode, cerebrovascular accident, then we can use a ACE inhibitor or ARB and a thiazide. And left ventricular dysfunction, that is congestive heart failure, we can use ACE inhibitor and thiazide and a beta blocker. Okay, if these are the first line of drugs which have to be used, they have to be followed. If there is severe heart failure, we can add an aldosterone antagonist, and if there is a block, then we can use hydralazine and isosorbide dinitrate. That is, if there is coronary artery disease present, we can use this. Now, how is JNC8 different from JNC7? The definitions of hypertension and pre-hypertension were defined in JNC7. They have not been addressed in JNC8. So there is no such term as pre-hypertension and stage 1 and 2 hypertension, which was described in JNC8. Pre-hypertension, stage 1, 2 hypertension were given in the 7th report of JNC, but not in JNC8. Okay. Now, similar treatment goals, they have been defined for all hypertensive population, and no distinction between uncomplicated and complicated hypertension and JNC8. Earlier, there were compelling indications and without compelling indications. These were the indications. Just to know about them, I had included. They were defined in JNC7. Okay, they were defined in JNC7. But in JNC8, these indications, that is the compelling and non-compelling indications, they have not been differentiated. No distinction have been made, and similar treatment goals have been defined for all the hypertensive population. And in contrast to JNC7, where thiazides were recommended as initial drug in patients without compelling indications, no such recommendation JNC8, as there is no distinction between compelling and non-compelling indications. So according to the JNC8 hypertension guideline algorithm, any patient which is aged more than 18 years with hypertension first need to implement lifestyle modifications. Among the lifestyle changes which have to be made, the first important is smoking cessation. We need to control the blood sugar and the lipids. We need to modify the diet. We need to get the DASH diet, that is the dietary approach, to stop hypertension. Dietary approach to stop hypertension. Okay, so this dietary approach to stop hypertension need to be made. We need to adopt a DASH diet, moderate the alcohol consumption, and we need to reduce the sodium intake to less than 2400 milligrams per day. Okay, and physical activity needs to be included, like moderate to vigorous activity 3 to 4 days a week, 40 minutes per session. That is 40 minutes of exercise per day, and at least 3 to 4 days per week need to be done to maintain a healthy lifestyle. So these are all the lifestyle changes that need to be adopted in order to bring hypertension to a normal level. Then we have to set a BP goal. That is, like, for more than 60 years of age, the BP goal is less than 150/90, and less than 60 years, it is less than 140/90. And for all ages, if there is presence of diabetes, then it is 140/90, and all ages with CKD presence and all races also, black or non-black, should be less than 140/90. But others, like the diabetes and more than or less than 60 years, they are divided into black and non-black people. The black, they should be initiated with thiazides or calcium channel blockers and not ACE inhibitors or ARBs, while the non-blacks, initially they should be started with thiazides, ACE inhibitors, ARBs or CCBs alone or in combination. If the blood pressure goal is achieved, uh, if it is achieved, then we should continue the treatment. If it is still not achieved, then reinforce lifestyle and adherence, and then titrate the medications to maximum doses. Okay, then we again check if the goal is achieved or not. If yes, then we should continue the treatment and monitor, and if not, then we reinforce again and then add a medication class not already selected. Like, we can add a beta blocker, we can add an aldosterone antagonist, and we titrate the medications to the maximum dose. Remember that, uh, start one drug and then titrate to maximum dose, then only add a second drug. If one drug is started, then add a second dose drug before achieving the maximum dose of the first. These 2 points have to be kept in mind, right? first dose, titrate to almost the maximum, and start the second dose before achieving the maximum dose of first. Begin two, or we can begin two drugs at the same time as separate pills or in combination. Okay, the initial combination therapy is recommended if the BP is greater than 20 by 10 mm above the goal. If the BP is more than 20 by 10 mm above the set goal, that is, if like in a person aged more than equivalent to 60 years, the person has a BP of 180 by 110 mm of mercury. Okay, and the target here is 150 by 90. So the difference here is 30 in systolic and 20 in diastolic. So it has a difference of more than 20 by 10, right? 30 by 20 is more than 20 by 10. The difference is more, so the initial therapy should be a combination therapy. Combination therapy. Okay, and the best to add is thiazide, ACE inhibitors, ARBs, or CCPs in combination. Always remember, do not add ACE inhibitors and ARBs together, others can be added. While working in an outpatient clinic, this is a case scenario we'll be discussing. While working in an outpatient clinic, a 53-year-old, 53 years old means less than 60 years, okay, healthy male without comorbidities, okay, no comorbidities, approaches you with concern over his blood pressure. He says his mother and father both had high blood pressure. Family history is present, okay, and he may have it as well. You decide to educate him on the blood pressure guidelines according to JNC8 guidelines, which of the following is true. Okay, so for less than 60 years without comorbidities, the target is 140 by 90. So it should be less than 140/90. So point A is blood pressure guidelines don't apply to persons below 60 years. This is wrong statement. This is absolutely wrong. For for his age, blood pressure should be kept below 150/80. This is a wrong statement. For his given age, his blood pressure should be kept below 140/90. This is a true statement. Answer is C. D statement is that for his given age, his blood pressure should be below 130/100. This is a wrong statement. So answer here is C. Okay. The next scenario is the same male patient. He comes back to you 10 years later. That is, now his age is 63 years. Okay. Now 63 years is more than 60 years. Okay. And he has been diagnosed with CKD. More than 60 years with CKD. With regard to the JNC8 guidelines, what should you tell him about his blood pressure goals? Okay. Any patient with CKD, any patient 18 years above with CKD, their blood pressure goal is less than 140/90, right? So his blood pressure goals are unchanged from normal age. His blood pressure goal was 140/90 earlier. His blood pressure goals are unchanged from normal age recommendations. He should keep his blood pressure below 140/90. This option has 140/90. Okay, and his blood pressure goals are different from normal age recommendations. They are different because more than 60 years, pressure recommendations are less than 150/90. So they are different from normal age recommendations because he has CKD. Because he has CKD, his blood pressure goal is less than 140/90. Okay, so they are different from normal age recommendations and he should keep his blood pressure below 140/90. This is the correct statement. Okay, the third scenario is a 36-year-old female presents to the ER for upper respiratory tract infection. On admission, her blood pressure is 180/100. So, which of the following is true? A. She can be diagnosed with hypertension. No, there should be at least two readings 12 hours apart. Since the blood pressure is 200/120, is below 200/120, she is not at risk of developing any end organ damage. This is not true. Okay, most cases of hypertension are symptomatic. No, most cases of hypertension are asymptomatic. Okay, and D is she should come back on two separate occasions, 2 weeks apart, to check her blood pressure. This is true. Now, a patient presents to the outpatient clinic for the third time. Okay, third time with increased blood pressure. Three times he has increased BP. Okay, they receive the diagnosis of hypertension. Now he has been diagnosed with hypertension and begin to discuss the treatment plan for managing their hypertension. According to current guidelines, how will you treat the patient? First is lifestyle modification. Okay, the first thing is lifestyle modification, and lifestyle modification includes a low salt diet, that is the dietary approach to stop hypertension, that is the DASH diet. Physical activity, it should be at least 40 minutes for hypertensive patients per day, at least 3 to 4 times per week. Okay, and third is stop smoking. These things should be followed. So recommend dietary modification and reassess in 3 to 6 months is the best statement. Before initiating any drug therapy, we need to do lifestyle modification, then only advise treatment. So next part, we'll be discussing classification of hypertension. That's all for this part. Thank you.